Hey everybody, welcome back. This is another Monday live stream for Synapse Care Solutions, and we are excited to be bringing back another Q&A call that we did. Oh my gosh, it's been 5 years ago now, where we're going to talk about the 4 most common things that are messing with your aEEG. So I want you to think about aEEG as more than just the brain function. There are many physiologic situations that we may encounter and other medical emergencies that come up that mess with our aEEG. So in this video, we talk about the maturation of the brain, we talk about medications, we talk about metabolic disease, and a few different medical emergencies like hypoglycemia and things like that. So I hope you enjoy this as we dive into the most common things that mess with your aEEG.
So today's topic, I wanted to just do a quick refresher on our 5 basic patterns of aEEG, because I feel like we need to know this in order to understand how medications affect this. So for normal voltage, we always want the upper margin to be greater than 10, and for the lower margin to be greater than 5. So continuous normal voltage, we want greater than 10, but most important for continuous normal voltage is that the lower margin is always greater than 5. Discontinuous, which is our pattern that we expect with our preterm babies, our upper margin is still always greater than 10, but because of the inconsistency in their brains, we allow the lower margin to be less than 5, or we expect it to be less than 5. Burst suppression is, by definition, the lower margin is always less than 5, but the bursts cause your aEEG pattern to always be at least 25 microvolts. So you have burst greater than 25, but then suppression less than 5. Then we have our low voltage, which is that upper margin less than 10, and typically the lower margin being less than 5, unless it's being contaminated. And then we have our inactive or our flat tracings, which are everything is less than 5. So when do we expect to see these? And I always think it's important that you think about, when do I expect to see these? Because then you can really quickly pick up on the normals and the abnormals. So continuous normal voltage, we expect to see this in our term babies, usually over 36 weekers. Our discontinuous patterns, we expect to see in our preterm babies. Not that we say it's normal, but we expect to see it sometimes in our sick term babies. Burst suppression, we see it in our very sick term babies, or sometimes we see a pattern that looks like burst suppression. This is for our extremely preterm babies. For low voltage is never normal, no matter how old you are. That's our very sick term babies or our very sick preterm babies. And then when you have inactive or flat tracings, these are for very sick term or preterm babies. So I like to always make things simple. And so I like to think about the influences on the aEEG pattern, and even, but for today, we're focusing on aEEG. And so we can think about these 4 M's: maturation, medication, metabolic, and medical emergencies. So maturation is easy, right? We've already talked about that terms and preterm babies have different kinds of patterns. And so we know, based on the literature, based on just decades of research, that aEEG maturation happens slowly over weeks, and that the most important feature of maturation is lower margin. So we can see at 25 weeks, if we look at our aEEG scale, here's our 0, 5, 10, and 100, we know that lower margin is going to be less than 5. And anytime the lower margin is less than 5, that's considered a discontinuous pattern. So we've got that lower margin less than 5, that upper margin greater than 10. And then as the baby gets older, we start to see here at 30 weeks where we're seeing periods, even if it's only for 30 seconds, where the bottom margin lifts up. We can see it up here above 5, above almost to 10. And we can see there's always variability, which is important. And then as we get to the 35-weeker, we see that the lower margin is greater than 5, except when the baby is in sleep, which is really this area here, where we go discontinuous only for those periods of sleep. So medications are hugely influential on our aEEG. And I like to look at this one here. This is actually a baby who was undergoing anesthesia. And so we start out here with a beautiful continuous pattern. And we've got the baby's getting fentanyl and is already mildly sedated. We have this continuous pattern. Then they begin to turn on the anesthetic gas. And you see, as soon as the gas is on, you see the lower margin begin to drift towards the 5. And we were talking earlier about the different montages, and this is the cross cerebral. So this is that P3, P4 view. So we're able to see more brain matter. So we're drifting down, becoming more of a discontinuous tracing. And then they increase the anesthetic gas, and we basically go into a burst suppression pattern where you have the upper margin hitting the 25, but the lower margin being very low and very consolidated and flat. And then you see that as time goes by through surgery, that you lose the bursts, but now we've turned into a continuous low voltage pattern where our upper margin is less than 10. Then they take off the gas, but the baby's still on fentanyl, and the baby resumes that continuous normal pattern. So I think it's super cool to see it all there together. So this is from Nidhi Shah from one of her studies that she did when she was a fellow at Stanford. Here's another one. So this is a 27-weeker. I came in the morning and I was reviewing this pattern and I was like, what the heck happened last night at 5:30 in the evening? And at first the nurse said, oh yeah, the baby got surfactant. And I was like, really? Wow, is that all? What else happened? And then they went back through the records and they realized that there was a single dose of Ativan given. And you can see this massive suppression. And I don't have all the slides in this presentation, but I have snapshots of the next 48 hours. This baby was in burst suppression for the next 48 hours. You can see the baseline though was really nice. There was all this variability and there was this really nice pattern for a 27-weeker. And literally we went to nothing after that single appropriate dose of Ativan. So these benzos have huge effects on the brain. And we know that synaptogenesis and brain activity is extremely important in order for normal brain structure and function. So we know that these drugs can have a huge impact. Changes in aEEG do happen after anti-epileptic drugs, or AEDs, are infused. This is Dr. Shani from Israel. He's done a lot of great work around this. And this is an old tracing, an old pen and paper tracing. But what I love about this is, again, orienting you to the paper, 0, 5, 10, 25, 50, 100. So here we have the tracing, quite a nice normal pattern, lower margin greater than 5, upper margin greater than 10, this really nice pattern, and then phenobarbital given right here. And we see, and remember the distance between these lines here, this is 10 minutes. So we see this medication given, and then for 10, 20, 30, 40, 50, almost 60 minutes, a suppression of the pattern, almost a burst suppression-like pattern, and then a recovery over the next hour. So this is the effect that we're looking for with anti-epileptic drugs, right? We're trying to suppress the brain activity. So this is a very common thing. What I've seen in practice is that the sicker the brain, the slower it recovers after an AED. This is, to me, a pretty healthy brain, not only because it was healthy before the dose, but then the quick recovery, 30, 45 minutes of a lull in activity as you're hitting that upper kind of maximum concentration and distribution in the body. And then the brain kind of is, okay, that's fine. We're at steady state now, I'm good. The sicker the brain, I find you give that loading dose and it never comes back up. So that's just my personal experience with that. Dr. Shani did say that there were clinically significant depressions of the lower border. It occurred in 25 to 35% of traces, and the upper border decreased in anywhere from 16 to a third of aEEGs. I've seen it to be almost, in my experience, almost always I see it. 12% of tracings, they changed to a worse pattern, and the average time for recovery to pre-drug administration was 2.5 hours. Some babies, like this one, really fast, 15 minutes. some really long, more like 15 hours. So I think it's just interesting to remember that these are going to be influences we see. This is another snapshot from another paper that Dr. Shawnee shared with us. And this was a baby who was having a seizure. So this right here, this uprising in the lower margin was demonstrated to be a seizure. So they loaded the baby with phenobarb right here. And then the baby had a complete flattening of the trace. The baby was receiving resuscitation. So this is not a seizure. This is artifact causing this increase. Then the baby was intubated. So again, more artifact. Then the baby was just being, what do you want to say? This was just stabilized. And so we were able to see that the pattern went from this burst suppression-like pattern to nearly a flat trace. They see here, there's more treatment, some sort of procedure being done to the baby. So this is artifact. Then you have here, again, a flattened, almost nothing trace. This turned out to be a 10 times overdose of phenobarbital, is what caused the baby's decompensation, need for resuscitation, intubation, and so on. So this was an interesting paper if you want to pull it out. Surfactant. I mentioned that other baby, the first baby I showed you with Ativan, that he had first got surfactant. And so there have been several kind of case reports of surfactant and aEEG showing a transient depression in aEEG after the dose. And there have been many speculations on what's happening with that. But this is actually a nice picture from one paper that Lena Hellstrom-West put out that shows here was the administration and then this dampening of brain activity for about 10 minutes and then a recovery. So this has been reported in several other case reports. They don't exactly understand what is going on, if there's some sort of ductal steal or if it's just like a redistribution of perfusion or what it is. But definitely when they told me the baby got surfactant, I was like, okay, I've only heard about that causing suppression for 10 minutes. So what the heck is going on that there's this ongoing suppression? And that's when the Ativan was discovered. But certainly you can see this very short-term depression. Last recording, we talked only about the medications, and then we stopped there, and I promised that we would go through metabolic and then some of the other kind of medical emergencies and complications that we see that also influence the aEEG and can, if you use it, also influence the NIRS readings as well. Christine Theta was a neonatologist, and she worked at Bedside, Johns Hopkins, and she was also a medical geneticist. And so she had a real interest very early on, and the citation is there at the bottom. So 2010, she actually was looking at aEEG and metabolic disease because she, as a geneticist and a neonatologist, had a huge interest in this. And what she found in this paper, and it's a great review of looking at babies with inborn errors of metabolism, but what she's found is that regardless of the cause of metabolic disorder, so whether it's acid-base, whether it's electrolyte, whether it's amino acids, or just urea cycle problems, it didn't really matter what the cause was, almost always caused a non-specific depression in cortical activity. And this was really a reflection, makes perfect sense, of a diffuse cerebral injury. These situations, these metabolic situations, are causing these kind of just overall sick brain, which causes this overall suppression of activity, matching the presentation of the baby, right? So if you think about these metabolic babies as they present, if they're undiagnosed or late diagnosis in that first week of life, they begin to come in and they're just floppy and they're encephalopathic and they're always, almost always, just really that low activity. So this depression of cortical activity goes along perfectly with that. So the other thing that these babies oftentimes have that we know are seizures. And so this again was from her paper in 2010, just showing these very extreme high voltage seizures and just recurrent repetitive status epilepticus, which we also know is oftentimes a feature or a presenting finding for these babies. So you can see here, this is marked with the A, where the baby's having these short seizures, quick uprisings, not as well defined to begin, but definitely some rhythmic spiky stuff. And then here at B, look at this very long, almost 30 minutes, right? So if it starts here, 10, 20, oh yeah, almost at least 25 minutes of this long uprising, and then looking in here and seeing this very classic spike wave pattern. So this particular paper by Christine is just really well done. I encourage you, if you haven't seen it, to go back and to consider it, and just some great case studies in there as well. The thing that she also remarked on were that the aEEG can be used as an objective marker for the effectiveness of our interventions. So as we begin to treat these patients and help them to remedy and reverse their metabolic dysfunction, that the aEEG will improve. And sometimes the aEEG will improve even before the baby starts to perk up. And as you can see here, I'm a very sick baby, and I don't know about you, but sometimes these babies come in and they do feel like the sickest babies in the units. Another metabolic situation that is getting more and more attention is hyperbilirubinemia. And of course, we are definitely wanting to manage hyperbilirubinemia, especially high levels of hyperbilirubinemia. And many people are using, actually, those of us that were working at Stanford right now, we actually are looking, we've put it into our top 10 list, is babies who come in the 95th percentile or higher. We are doing aEEG on those babies as a screening, just to be looking at what's going on. I hadn't used it in the past as a general baseline. I'd used it in the past when babies with hyperbilirubinemia would come in with funny movements, either just funny posturing, and I couldn't tell if it was just related to the hyperbilirubinemia or did they have something else going on, infectious or meningitic. And so I had used it in the past to rule out seizures, and not really thinking about it so much as just kind of neuronal dysfunction and depression. But basically, some of these papers are showing that there are some changes, up to 20% decrease in amplitude without clinical symptoms, and that there is a delay in maturation as well. So interesting that the bilirubin, we know it can be toxic and it can cause injury, but interesting to think of it, I guess, in this way as well. So 2011, Liu described 10 babies with acute bilirubin encephalopathy. This is in China, where they have a huge issue with that due to some of their genetic predisposition, but abnormal EEG in many of them, and 80% of them had seizures. So again, just this very large percentage with seizures. And then 2017, Dr. Zhang, another physician from a different hospital in China, found that 50% of babies with hyperbilirubinemia have disrupted sleep-wake cycling, which is interesting as well. If we think about back to some of the talks we've had before about sleep-wake cycling and the importance of sleep, it's interesting, right? Because if you think about those term hyperbilirubinemia babies who come in and have been at home maybe and then are readmitted, they really do have a difficult time sleeping, right? They're either irritable and cranky, or they're just so lethargic that they're just not able to eat. So it is interesting to note that aEEG picked up this kind of disruption in sleep-wake cycling, which I thought was interesting. Another metabolic situation that we encounter a lot in our NICUs, right, is hypoglycemia. And seizures, obviously due to hypoglycemia, don't have really a specific EEG pattern. So there's not a specific morphology when we look at that, but certainly we know that hypoglycemia, it's a hot topic, right? And we wonder if babies are not having more transient hypoglycemia than we know. And I just recently heard that Sick Kids in Toronto is actually doing continuous EEG, aEEG, along with some continuous blood glucose monitoring, which I find very interesting. I think that it's going to be exciting work when they publish that, so that we can begin to see what's actually going on. So this is in international units. So for those of you watching from international units, you'll know what this means. But basically, lower numbers are bad, right? So just like with our milligrams per deciliter. So you can see here, this aEEG is pretty suppressed. And then you can see these lower values, so 1.4. And this low flat tracing, so that's the continuous low voltage. And then starting to see some disruption. The value was 1.4 and dropped to 0.2 on very low values. And you can see here these little uprisings, potentially seizures, difficult to know unless we see it. But here, look at this amazing increase. And you can see the bottom margin moving upwards. And this is all after the blood glucose had been corrected. So this was a 38-weeker, 4 days of life. So this isn't even a preemie. This is a near-term baby and 4 days of life. So right here, improved. And then another one, not a super great tracing, but then look at here when it drops to 0.6. Again, very low values, and then almost a completely suppressed flat trace, and then some correction there. So this is from Lena Hellstrom Westis, 1989, basis with the old cerebral function monitors, the electromeds that they did. So just interesting to see some of those. Another metabolic feature that I think is really important, this is from Frank Van Bell from the Brain Monitoring Conference in 2015. Probably all of you have seen this. So he's looking more at NIRS and looking at some of those situations. And looking here, we've got the pulse ox here. The blue is the cerebral NIRS. So as a reminder, the NIRS is just that end organ saturation. It's a mixed saturation. So your pulse ox is going to be arterial. Your cerebral NIRS is a mixture of cerebral and venous blood. So it can reflect perfusion. It can reflect also oxygenation status and extraction, oxygen extraction and utilization. The red line here is the mean blood pressure going along. And then the PCO2s are the little brown dots. And you can see, look how low the PCO2s are here. Our pulse ox is showing fantastic, which is one of the things why we need these. You'll see here that the blue line is very low. And just as a reminder for cerebral saturations, we want them somewhere between 60 and 80, and below 50 is that cutoff of danger. So we like them, again, 60 to 80. Not that higher is better, but just in that range. So you'll see that as the PCO2s are really low, look how low the cerebral sats are. So we know what a powerful influence, I guess I'll say, CO2 is on our brain perfusion. And so as these CO2s, this hypocarbia being so low, then causing our cerebral sats to be so low. And then once these are corrected back into that almost normal range, we see that they correct. And so just what a powerful thing. And many of our monitors now, I'm showing this multimodal approach where we can see the NIRS, the aEEG, and see the physiologic as well. So super important to see all these together. This is another great paper by Dr. Shawnee's group from Israel. And this is looking at a small baby, 24 weekers, 2 days of age. And so if we could almost imagine the brain basically shutting down here, and then an improvement once we correct the blood gas. So just again, remembering that the function of the brain is so dependent on these metabolic factors that when we look at aEEG, there's maybe more under the surface than just the pattern itself, thinking about all these influences that really exist. So have some of you encountered these kinds of patients before? And have you monitored them? Have you been monitoring them? Does this kind of open your eyes to maybe some different populations even? If you haven't been monitoring these babies, I'd invite you to maybe consider bringing these up to your group and to think about, again, this is really about getting beyond just cooling, right? It's obvious we need to be doing brain monitoring during cooling and for HIE, but there's so many other applications for aEEG that I think really begin to paint a much bigger picture for us.
All right, I hope you've enjoyed today's replay. If you'd like to get the resources that I mentioned in this video, check the show notes below, and you should be able to find those there. So I welcome you to ask any questions you have in the comments, as well as always feel free to email us and follow us on all of our other social channels. So hope you have a great week, and we'll see you next month for a new series called Social and Emotional Caring in the NICU. So I hope that you'll enjoy our new series coming in July, and they'll be released every Monday, just like these.